Welcome back to another episode of the Patient No Longer podcast. A theme this season has been pulling different walks of life within healthcare together, and today will be no different. I'm very excited to introduce Lynda Barrett, who's the Vice President, Strategic Planning and Chief of Governance for Emory Healthcare. Hello, Lynda.
Hi, Ryan. Thanks for having me.
Well, I'm excited to have you. I'm very intrigued by your line of work and in your lines of work, really. So you've been Associate Vice President as well for Strategic Planning for the Woodruff Health Sciences Center. And also, of course, your work at Emory. You have over 25 years of experience in healthcare. Actually joined the Strategic Planning Office of Woodruff Health Sciences Center at Emory University in 2008. But you also worked in strategic planning in general for almost 20 years. Really excited to talk about strategic planning specifically. So let's start with that. Now, you live in both worlds of governance and strategy, but if we split off strategy, I want to ask a question that I've asked some other folks this season who sit in strategy, and that is, what part of a healthcare organization could use strategic planning the most, but typically doesn't get enough of it or enough exposure to strategic planning?
Well, that's a really great answer. Great question. To start with, of course, you have the system strategic plan. That's where everyone needs to cascade from and be aligned to. I think about who we work with the most for strategic planning, and it's the typical growth areas. It is the major service lines, heart and vascular, cancer, musculoskeletal. But what we've really found in our office is every area needs strategic planning. And you kind of go to the areas that don't get it as much. And, a couple of different areas that come to my mind. We have what we call core services. So those are the services that cross the foundation across the health system, things like imaging, things like pharmacy, things like palliative care. Those are foundational to help the patient, no matter what kind of disease they have. So we've found it really important to have strategic plans for those services also, along with the traditional ones. The other areas that we've done strategic plans are our corporate services. So we've done strategic plans for our digital group. Of course, that's so incredibly important when you look at our digital roadmap for all the changes that are being made on the digital side. It's incredibly important to have a strategic plan, or our people team. Workforce being so crucial, you have to have a roadmap to see where they're going for that.
So, and I like that you've got, an overall roadmap, overall strategy, but then you do split it out. I've had this conversation with other guests just this season about how you really do have to think about those different services, which can be wildly different. You mentioned palliative care. You mentioned something like imaging. I mean, there can be two different contexts and scenarios for why a patient is using those services. And yet the patients come in with a set of expectations. Is that part of mapping out those different strategies or micro strategies, is trying to understand where the patient is at when they're using those services?
It is. It is part of how do we meet that patient need, and how do we also have that system approach to make sure we're consistently meeting the patient need in those services across the whole organization. And it also is creating that roadmap of where should they grow, whether it's the physician providers, overall, and also by site. So just understanding those factors is incredibly important.
Yeah, that makes a lot of sense. I mean, meeting the patient need with the system approach, when you can pull that all together, is critical. I think some systems really struggle, and we get so tied up in all the things we're doing as a system that the patient can almost be an afterthought or an end result, that the experience you end up having is kind of what drops out of all of that planning. I want to talk about the other side before we get too far, and that's governance. And governance has been a passion of mine. Of course, NRC Health is also part of the Governance Institute. We've got a relationship with them, and it's essential. Good governance in healthcare is essential. I find it so puzzling at times how different organizations with different boards, how they go about things in totally different ways. And some of these are the same responsibilities across healthcare, and yet in an organization you find something totally different. What is your experience at Emory, which is a brand everybody knows? And specifically, when you look at governance, how do you take that other part of you, the strategy, and how do you inject a strategic approach to governance?
So, this governance role is new for Emory Healthcare. Emory Healthcare is wholly owned and wholly part of Emory University. So it's a very complex organization and you have different layers. So, of course, we have the Emory University Board of Trustees, and we even have a lot of committees, such as the Woodruff Health Science Center Committee, of which Emory Healthcare is part of. But there is also the Emory Healthcare Board. With some changes that were made in the past 2 years, there was a recognition that Emory Healthcare needed to have that strategic approach to governance, and they needed to have someone dedicated. So it wasn't just the CEO doing it kind of on the side. So that's when I was approached to take this role. And it was, I thought, a wonderful tie to my work in strategic planning, because what we want governance to be focused on is the strategy of Emory Healthcare, along with the fiduciary responsibility. So from my perspective, I'm able to identify what is going on across Emory Healthcare with the strategic plan and be able to say, this is, help guide to say this can go to governance, this should go to governance. This is kind of the input we need.
I mean, that's really important because you're kind of in that gap, which can be a big gap if you're not careful, and you're almost a gatekeeper for information getting to the board. What is the board's reaction when you do bring in certain elements of the strategy? Do you find them engaged in that? Is that something that they're hungry for? Are they puzzled by it because they're thinking they should be over here with governance? How do you navigate that?
So it's really interesting because you do have very diverse members of the board. We have physician leaders that are part of Emory. We have board of trustees at the Emory level who are not clinical. We have community members. So their knowledge of healthcare is very diverse. But I think that the board members overall are extremely interested and invested in the strategic decisions of Emory Healthcare. And, quite honestly, a lot of those board members are patients.
Yeah.
So they bring that lens also to say, let's make sure we're keeping the patient and the community that we're serving foremost in our mind.
That's a good point because you're not the only one that can find yourself kind of in between two worlds, because in fact, board members oftentimes feel that way. I had a board member once in my very early days with the Governance Institute who described himself as 1 foot on the dock and 1 foot in the canoe. And whether the hospital side or health system side was the canoe or dock doesn't really matter, because you're not totally installed. It's not the same as being a day-to-day employee. And yet you know a lot more than the average person walking around the street. So I think board members can be such a fascinating advocate. Do you find at Emory, can you then draw back from the board? I mean, you're bringing the strategy to them where it's appropriate, where it's part of governance. Do you draw back from them inspiration or other ideas to then take to the patient experience on the healthcare side?
Absolutely. When we have these discussions, and by the way, there is that fine line between the board advising on those strategic issues and also, but also avoiding having them get into the management of operations.
Very fine line.
And there's a very fine line. But they do push us appropriately in certain areas. Access is huge. And they, at almost every meeting, they are talking about how are we improving access for our patients. So they keep us honest by keeping that focus. They've also very engaged with workforce. What are we doing for our workforce? How are we supporting them to be able to recruit people and retain them?
They can serve as a really nice proxy, so to speak, for some patients. And I always feel board members are fearless about talking about their last patient experience.
Oh, yes.
Whether it's a HIPAA violation or not, I'm not sure, but they will tell you, and they will tell you when they were frustrated.
Yes, they will.
We could talk about board members all day, and governance is such a fascinating piece, and maybe we'll come back around. I want to talk also about Emory as an academic medical center, a really powerful brand. as I was reading up for this, you've got a president on Emory's side that talks about being innovative and inventive. And I love that word inventive. You don't really hear that. Everything's sort of been captured by innovation. And so when you've got the academic side that's known for some of those things and churning that out, and then you've got a health system attached to it, which you traverse all of those moving parts, how do you feed off of that? And even for someone listening who doesn't have an academic medical center behind them, is there ways in which they can just take a more innovative or inventive approach?
So the beauty of the academic medical center, being part of that academic medical center, is tripartite mission, and innovation is just core to that. This is our differentiator in the market. And we have to keep that top of mind. So when we it had the beauty of working closely, of course, we're partnering with the School of Medicine, along with the other schools, especially in the Health Science Center. We're able to benefit from the research that is being done every day across Emory and across the Woodruff Health Science Center. So that supports Emory Healthcare. We're also a benefit from having, say, innovation in education and having the workforce of the future being trained in our walls and being able to help that change and improve what we do. So that is the beauty of the academic medical centers, to have those factors there. And I think that's really important for the health system or the clinical care delivery arm of that academic health center to really embrace those innovations.
I like the way too that the academic medical center isn't, something that according to the patient's perspective is just for show. I mean, what's happening there is really feeding into all arms of the organization. And I think that's really powerful. Same thing about research, just being driven off of that engine of research is a huge advantage. On the innovation part, it's so fascinating to me because I feel like innovation is one of those words in healthcare that we've used, and we've used kind of like quality, where we use it so much that honestly, sometimes when I'm listening to someone talk about innovation, it's not even a real word anymore. I don't even hear it. How do you break away from that? How do you spot what would truly be considered innovation versus people just talking about innovation?
I'll start by saying, yes, it is definitely overused.
Same experience.
Yes. And even within Emory, there are so many groups that have the name innovation in the name, and trying to figure out what's different between this one group or the other is difficult. And say, how are they different from this other innovation group? So this is something that honestly, we're just trying to, I guess, a fine line between saying what is truly innovation. We have a new department, newly created Department of Transformation, which we also call innovation. And we have a chief transformation officer for the first time. And but we also have an operational excellence arm.
Okay.
And the question is, okay, what's the difference? Who goes through what? So the way I think about it is, for transformation or true innovation, how is it truly completely changing how we deliver care, changing completely how we do our work?
Yeah.
Versus process improvement, making things more efficient. So I think it has to be a true transformation.
Well, and those words, innovation or transformation, and you can folks listening can plug in their own version of that, or watching, you can think about that word, but you really do have to go back to the root of the word. If it's transformation, it can't be something little. It can't be, we've sort of, and it's okay, because I think that helps you separate out what is truly transformational, and everything else. It's not that it's bad. It's just that it might be really good to change things a little bit here or a little bit there. And in the long run, a lot of that can end up being transformational, but we shouldn't think of it all as such. We can talk more and get into more, especially the academic part, but I always like to take a little break from healthcare and do what is now very commonly known as our speed round. So you've not seen these questions, Lynda, but they're not healthcare based and very low stakes. We just love to do this to, get more about you as a person. So I'm going to rattle off 5 quick questions as part of the Patient No Longer speed round. You ready?
Okay, I'm ready.
Coke or Pepsi?
Coke.
No hesitation there.
Atlanta.
Sure. Of course. Power of the brand. Fiction or nonfiction?
Fiction.
Morning person or night owl?
Morning.
Got a lot of morning people on this season. Favorite movie or TV show of all time?
Ugh. I'm definitely Gen X. I'm going to say Friends.
Friends, okay,
Yes.
sure. We got some. I'm sure we have some Friends fans listening. East Coast or West Coast?
East Coast.
East Coast. Okay, very well. That was very efficient. Okay, back to healthcare. So we've mentioned Emory. We've mentioned you're part of a prominent academic medical center. Let's talk about the power of brand, because I think there was a world where branding seemed like the end all be all. Even 10, 15 years ago, I remember in my early days in healthcare, it was really about the brand. Of course, you have a powerful one that you represent here. But then you hear other things like, convenience is all that really matters. And if I can get in and get access, which is one of your, core focuses that you have as an organization, is access and improving it. Where do you come out on this? Is brand as important as it was 10 years ago? Is it important in a different way? Is it less important? What's your take?
Brand is incredibly important. And a lot of the work that we do, and actually our board does, is they need to make sure that we're protecting the brand, because it's not just Emory Healthcare, it is the entire Emory University. So I'll just start by saying that, and we're very proud that we do have a very strong brand in the Southeast, across the rest of and across the rest of the United States.
Sure.
Okay, saying that, if we cannot give convenient access to our patients, they're going to bypass the brand and they're going to go where they can get care. So we have to back up the brand by providing very convenient access, whether that is just getting an appointment to see a provider as soon as they want to see that provider,
right,
or having that geographic access or virtual access. We've got to be able to back that up and provide that access for the patient. We also have to back it up and provide the best experience and the best care. So the brand is meaningless unless we're able to truly back it up.
Oh, that's very well said, and a really good context of how to think about brand. When I think about brands, and this is something that has come up in every conversation, I've usually brought it up in the podcast this season, but there's other brands out there that aren't health systems, aren't academic medical centers, and they're very powerful. You have the CVSs, the Walmarts of the world, Amazon, and One Medical. What is your approach to those brands? Because they come in with a lot of brand equity, certainly. They don't all stay in healthcare for very long before they pop in and pop back out, but we get the feeling they're always going to come back. What's your take on these sort of disruptor brands?
So the way we're looking at these, called the disruptors, is we have to decide, are we going to compete directly with them, or are we going to partner with them? Mm-hmm. So you actually mentioned two brands that we have partnerships with. So we do have a partnership with One Medical. They are part of our clinical integrated network, and we have their sites around the Atlanta area. They have their name, but they also have that as an affiliate of Emory Healthcare.
Yeah.
So we're able to hopefully leverage the power of both brands. And when they first came in, they were new to the market, so no one really knew what One Medical is. I think since Amazon took it over, it's starting to have a stronger name recognition. But I think that partnership has been a good partnership for us. Same way with CVS, we have a partnership with them for their for their minute clinics, and that's the approach we have taken, is to work with them. Those are great access points. Talking about access, we've heard about the shortage of primary care and how difficult it is to truly be able to meet all the needs that people have for primary care services. It would be incredibly difficult for us to be able to recruit as many primary care physicians that are needed in the Atlanta area and throughout Georgia. That's why it's incredibly important to partner with different groups to be able to meet those needs.
Yeah. incredibly important in the way you've thought about it strategically and filtered one way or the other and then committed to that and what that adds to the brand in a lot of ways. I mean, it seems like there's some two-way benefit there. Another thing that I wanted to ask you about in terms of Emory is one of the things that's really important, both university side, the healthcare side, is equal care for all. We've strived as an industry for equal care. We've talked about it a lot, especially the last few years. I think some are disappointed in how far we've gotten or to inequities as well. What's your take on this roaring into 2025?
So I agree. I think the industry has a long way to go in healthcare for equal care for all. But I'm seeing a lot more movement and a lot more focus on this than I ever have before.
Yeah.
The past couple of decades I've been in this field.
Yeah.
So I think there are some health systems that are doing this extremely well, and I think we can learn a lot from them. Things that I'm seeing that are needed is we're focusing a lot on first just collecting the data. The data is not available. It's hard to make improvements if you don't know what you're starting with and what it looks like. So I think just having that available, and then also showing the why. Why should we be doing this? I've sat in meetings where we've had people say, I don't understand why is this a problem?
Yeah.
And you have to show again the data to say this is why we're seeing,
Right.
this is what the issue is. And then looking at what are our community outreach, and another let's say challenge is really being able to identify all the partnerships that are available throughout the community. There are so many resources out there that the big part is making those connections.
And the spirit of partnership I hear is really refreshing. We work with a lot of big brands, and sometimes they can be very protective, and that doesn't lend itself to partnering. Whereas you've really found a refreshing approach where it lends itself to partnership, and it can be quite powerful. Your point on data could not be better made, because a lot of times when someone says, well, we haven't had much progress, I'll ask as a researcher, part of NRC Health, where did you start? What was your starting point? Well, we didn't really have it. We just jumped in, formed a committee, and went. Well, how do you know you made progress if you don't know where you start? It's like you need the start here sticker from the old mall directories. I also want to ask you about one more issue that's come up throughout seasons of Patient No Longer, and I think it's really popular right now because we want to focus on the patient. Patient is the first word of this podcast. We also know workforce is a huge challenge, and sometimes there's a tension between who we focus on. You guys plant a flag and talk about how patients come first, and I really like that. But for those out there who would say, well, you've got to take care of your workforce to take care of your patients, or it's not just when they're patients. There's some other arguments that have really come up. How would you address that as you think about your approach to patients come first?
So I go back to what is our core purpose? Our core purpose is improving lives and providing hope. We do that, first of all, for our patients and the families. We do that for our communities, but we also do it for our people, whether it's our employees, our providers, the people who are training throughout Emory Healthcare. So we do have people as part of our North Star. And so if we don't have people as part of our North Star, we're not going to be able to care for the patient.
Yeah, that's so well said. And it doesn't have to be a tension in that way. I also love that your core purpose is short enough that you can remember it and say it. Because some of those purpose statements, they don't come into the normal conversation. I want to ask you, this is really a people question to end with, and we ask everyone to end the podcast episodes. Let's talk about, you're at Emory, you're getting in an elevator, and a person comes up, sneaks in the elevator with you and says, you know what, Lynda, this is my first day in healthcare as an industry. So knowing that they're on day one of healthcare, what would a piece of advice be that you'd give that person?
So I would say the first thing to do, to keep in mind, is be comfortable with change. It will never be a normal day. I don't even know what normal is. And you you just have to keep rolling with it and changing and keep making improvements. The other thing I would say is just what we were just talking about. You do need to make sure we're doing this for the patients. We're doing this to make people healthier. We truly are, improving lives and providing hope. So just keep that in mind in everything you do.
Always good to keep in mind. Your part about being comfortable with change, for those just listening, I was nodding my head vigorously. And I think a lot of people who have been in healthcare for a while would completely agree about your view on change and what is normal and just being comfortable with that. Excellent advice. Thank you for peeling back the layers of Emory and how you approach strategy and governance and tie it together. No small task, but you really do a great job of that. And I also just want to thank you, Lynda, for being a part of the Patient No Longer podcast.
Thank you so much, Ryan. Appreciate it too.
Thank you.